second, but I wanted to throw a question to Ray that I've had in my head for a second, or for a few minutes. Back when post-exposure prophylaxis, when I was doing some reporting and writing on that 15 years ago, one of the big fears in the community and in public health as well was that post-exposure prophylaxis would lead to people engaging in unsafe or irresponsible behaviors, which can also, one of the elephants in the room is we're not necessarily just talking about HIV, we're also talking about hepatitis and herpes and this and that and everything else. Syphilis, which is much bigger around here than people know. In your experience, did post-exposure prophylaxis drive anything like that? Because a lot of people have the same concerns about pre-exposure prophylaxis, that the medicalization of it or other things will give people false senses of security. Condoms block more than just HIV.
So we can actually go a little bit into post-exposure prophylaxis. So how many people are aware it exists by a show of hands? Okay. And so do you know how effective it is? You had to guess the number.
It depends on how you use it. I know how effective you do it, the way you're supposed to the whole time, instead of 90-something.
Yeah, it's 90%. So it's pretty effective if you know about it. But you have to get to your medical provider within 3 days. So ideally within the first 24 hours, but at least within 3 days. And so to me, really, the community just has to know about it to know it's available. For the patients that we see for post-exposure prophylaxis, the majority actually end up being scared because they're being put on HIV medications. They might get side effects from it. So at least when we talk to them, they report actually less sexual behavior afterwards. Pre-exposure prophylaxis might be a little different. If you take a pill a day to prevent infection, you might have a false sense of security. When they did the large studies, one's called the IPREC study, the people reported more condom use and less sexual behavior, but it was a study and people thought they'd be kicked out and there was financial incentives. So I don't know if I necessarily believe it. But we'll see overall. And then since PrEP is relatively new, how many people have heard of pre-exposure prophylaxis? So most people. It's just interesting. So do you know how well it works if you take the medication every day? So it's a combination of 2 HIV medications. You take one pill once a day.
Well, did the study include condom use? So it's extremely effective. It's in the 80s or 90% effective, but the people on the trial regularly use condoms. So
They said they used condoms, but they didn't report. There's 4 different trials. The condom use was eliminated out of some of them, but it actually works pretty well. It was like 95% active. For those who actually took it, and the way they did it was they actually check their blood for the medication in their blood. So those are 2, to me, good options for people. I don't think either are going to be solutions for the community, but I think along with behavioral interventions, medical interventions, it'll work. And then for someone who's HIV positive, who's on HIV meds and has an undetectable viral load, it reduces the risk of transmission by 96%. So that's a great strategy, but that's if we could get everyone on antiretroviral therapy and everyone suppressed, which is not happening currently.
I'm quite loud. Oh God, I don't like this at all.
I'm just gonna talk like this. That is terrible. So we were talking. You said something about paracentric messaging, and then you touched on this at the end of your response. Talking about fear-centric messaging and how fear messages don't work, and how that might. And it sort of ties into the 2 comments I'm going to make. The first one being how you were talking about healthcare providers talking to young MSM about their health, and how it's in an ideal world they would say respect yourself and respect your partner and their condoms. But I think that outside of the messaging that we provide, and I think that the district has improved its messaging immensely with positive campaigns like rubber revolution and wrap it up. It's not saying use condoms or die. condoms is fancy, right? So, talking about having healthcare providers talk to their people they provide healthcare to in the same way, instead of saying, oh, you're gay, oh, well, use a condom because you're doomed. And I think that that's the default message to young people, and those messages don't work. They've been proven not to work. And talking about fear as well, so that's a two-part question. We were talking about stigma, and I think there's a very fine line that we're walking with young people, or when I say young people, I'm including myself because people that weren't sexually active during the beginning of the HIV/AIDS crisis, about destigmatizing people living with HIV, but stigmatizing the disease. So saying that you do not want to be living with HIV is extremely inconvenient. Like at the bare minimum, you just don't have to take a pill and the side effects, but like do not disrespect people living with HIV. How do we navigate those two very different messages about one very real problem? So fear messaging and then also destigmatization.
Okay, there are different, you touched on those different forms of stigma out there, and I think we continue to see that about gay men. And we need more messages, and one of my projects is to do a stigma reduction campaign for around gay and bisexual men, which to me is, I think, a significant social determinant as to leading to behavior. If you're getting these messages that are reinforced, or that there's something wrong with you, then that will affect whether or not there's any value you have to your life, and therefore I don't have to pay attention to that. And there's certainly other studies that point to some of that, points to certainly around depression, and we see a lot of depression among young gay men, so depression has an actual health behavioral impact. So we need more positive reaffirming messages to gay men, young and adult gay men, that aren't necessarily, that isn't necessarily directly tied to HIV, because again, not reinforcing another stigma associated with that it's only the gays that get HIV. Well, we know that's not the case. We know that's not the case in the district. And that effort is not just also addressed to young gay men and adult gay men, but then also the general population as well. We did a focus group. We're working with, you're not Metro Teenage anymore, but we're working also on a new social marketing effort around young people that we're bringing in more of our community partners into. So we'll be getting phone calls. But what we're looking at is addressing some of the peer norms that are out there. And there are some negative peer norms that have to do with being gay. Because when we do focus groups with young people, a mix of young people, we were asking them about, tell us what are positive images for you, what are sort of not positive images for you. And when the picture was of two young men together, that was considered not a positive image. And actually, even one of the findings from the results of that focus group said that one of the reasons why young heterosexual men, start engaging in sex as young as possible is so that they are not perceived as gay. Which kind of floored me. In some respect, it's hard to be surprised after all these years, but at the same time, it still says there's something wrong there. There's something wrong for the young heterosexual man who feels like he has to have sex at 14 so that somebody doesn't label gay and something wrong that he thinks there's something negative attached to being gay.
I also think that there's an inconsistency problem with the way that we talk about stigma. And I'll give you a perfect example because I'm working on it this week and I'm glad that you asked this question. So right now the FDA is accepting public comments on its blood ban for taking blood from gay men. They're considering shortening the deferral period, which right now is lifetime. And so I was asked to draft some comments for NASDAQ, so I was drafting it. And one of the arguments that I made for the ban being repealed entirely is that under the HIV/AIDS strategy, which was unveiled by the White House in 2010, for men who have sex with men, one of the main points is to reduce stigma and encourage routine testing. So HHS wants us to encourage gay men to get tested routinely as a way of reducing stigma. But down the hall at FDA, they are saying that gay men should never get blood because they're at extreme high risk by virtue of the fact that they have had sex with another man since 1977. So to me, that's an inconsistency. You can't say on the one hand that you want to normalize getting tested and making that a part of routine health care as a way of reducing stigma. And then on the other hand, to say, oh, well, you can't get blood because you've had sex with a man since 77. I mean, that is an inconsistency that we should be pointing out to say, this makes no sense.
It's definitely a double-edged sword because, it leaves a lot of confusion, especially with the younger concrete thinker generation, that, okay, we know that HIV is still stigmatized, but yet we will send them a message and tell them, okay, you haven't seen the rhetoric that has happened, over the past 30 years, because people who've died and moved on and succumbed to the disease of HIV and AIDS. But we say, oh, well, it's a chronic illness, and if you do these things, you can live like a person who has diabetes. That, if a person comes to another person and says, I have diabetes, they're going to be, oh, are you taking your insulin or whatever you're doing? Versus if a person comes and says, I'm HIV positive, you poor thing, because now they're just looking at you as this HIV positive gay person. And so your message is totally construed because when people look at you, they're going to still look at that stigma behind the fact that it's HIV, behind the fact that you're an MSM. So all of those things continue to create that chaos and confusion amongst people about what needs to be stigmatized. Actually, none of it should be stigmatized. We should formulate it into a way where there is that, there is that candor of camaraderie among people who are public health workers and are in the field to be able to take those extra steps to help diminish the confusion. But it's not really happening fast enough, and it's disappointing enough to know that DC, with the statistics that we have, 3% of the population being infected with HIV and AIDS, but yet we're still sending these messages that